So I'm very pleased to be part of the Big History Institute. Delighted, in fact. I run the Australian Institute of Health Innovation. And so I'm a bit different from some of the people who've appeared before you who are experts in climate change or earth sciences. I'm actually a psychologist by training, and I do research on the health system. And that's very important in the Anthropocene for the single reason that I've noticed as an audience, you are aging. I don't mean to be personal or impolite. And you're going to age and use more healthcare. There's a direct correlation. And as some of the scary things that have been pointed out about the Anthropocene progress, although that's not a good word to use, I think, because that implies good things are happening, then we're going to have more need for a health system that copes with a different kind of world. And so that's my ad for how important my work is. So I'm going to take you on an exploration of that. But before I do that, I've been sitting here quietly, which is very difficult for me, for 2.5 days. I notice you master it very well too, David. You gave a keynote and you've been relatively quiet ever since. Fantastic. But we'll hear from you later, I know. I've been sitting here quietly and I've been thinking, we've been talking a lot here about we and they and it, meaning problems. Nobody's talked about I, which is interesting because, change begins with me. So I want to talk about that first before I actually give my talk. Because I think we've perhaps been too much the scientist and not enough the human being. What am I going to do, or what are my characteristics, rather, in response to all this Anthropocene stuff? So I want to talk about that first. So, firstly, thank you very much for the very kind invitation and the very kind introduction. I do health systems research. I like to say, though, that I don't splice genes, I don't cure cancer. I do something much more important and complex than that. What I do is I try and figure out how the health system works at the pointy end where clinicians deliver care to patients. And then I try through my research to illuminate that to try and make it better so we deliver more better care to you. So that's what that says. And there's 3 groups. If you want career advice, by the way, I'm running a research centre in the Institute. I'm also the foundation director of the Institute, so don't come to me for career advice. That's madness. We have 3 centres. One's the Centre for Healthcare Resilience and Implementation Science, which is code for how do we create a resilient health system given what's coming downstream. One that adjusts and flexes and delivers good care across all sorts of scenarios and circumstances. Second group is the health system throws up enormous data. Genomic data about you, but also data about how health systems function. And we've got a group doing that led by Enrico Coira. And the third group is Joanna Westbrook's group, and she runs a whole program of research to try and improve safety for patients. And I'm going to dip into a little bit of that shortly. Be on your guard, though. This isn't a diatribe of me to you. I'm going to ask you some questions shortly. Before that, a disclaimer, though. And no one's done this so far. You probably have noticed already I'm a rich white dude. And I have cognitive biases of all different sorts and kinds. And I don't have to be a psychologist to know that. I have extreme views that masquerade as normal. I carry cultural artifacts everywhere I go, like this nice suit and this shirt made somewhere else other than Australia, and this iPhone with all its power in my breast pocket. And I carry psychological baggage, the psychological baggage of Homo sapiens and my specific own little black box of psychological baggage. And I just want to point out that I'm weird. Had you already figured that out? Thank you, David Christian, for nodding yes. What do I mean by being weird? Well, let me explain about weird. I'm Western, educated, industrialised, rich and democratic. That is to say, I have a set of values that aren't necessarily shared with the rest of the people on the planet. I'm highly educated. In fact, the average typical person I deal with has a PhD. That's insane. That's not normal. I'm industrialised. I'm a product of the Industrial Revolution, which was brilliantly explained in a 13.82 billion year paradigm by David in his keynote address. I'm rich. I have a professorial salary, some superannuation, a nice vehicle, a nice home, a nice office, and that's rich beyond imagination compared to people in the entire history of humanity and compared to most people on the earth right now. By the way, I'm going to ask you a question, and I'll put the seed of the question first. Where's the other people who represent people who are on $2.50 a day in grinding poverty at this conference? Are we speaking on their behalf? I'm going to come back to you on that. And also I'm democratic, and that's unusual in human history too. I can vote for a politician. Most people on this planet right now, and almost everybody in human history, has not had that right. So I'm weird. I am totally unusual compared to humanity now and forever, for 2 million years. I'm also, as well as being weird, a left-leaning liberal who believes in science, progress, social movements, continuous improvement, and the perspective of big history. Do you notice I'm in a funnel and narrowing myself down to my characteristics? And so I'm starting to wonder, as I carry like bags of cement across the landscape, these characteristics that I'm explaining to you, there's a jarring note. I'm actually not evolved for the characteristics I just described. They are my particular characteristics, but I'm mostly evolved in the environment of evolutionary adaptedness for surviving on the African savanna. And that's what my predecessors did for the last 2 million years. So this is like the blip that David explains to us, but extremely interesting blip. Now, it's never happened before in human history or prehistory that people like me, and of course you, except you're not a white dude necessarily, and you're not a male necessarily, but it's never happened before in human history and prehistory that people like us existed with this cluster of attributes. Now, what we're asking ourselves to do is, at the same time as hold the views that we do, accumulate things and wealth, bond with others, but largely bonding with others in our own tribe, like we're doing right now. There's almost no one outside our tribe here. I've learned how to be curious about the world and get an education about it in order to survive, but also in order to further my career. And I'm quite willing to defend my patch and my views and my family. These are the attributes of a modern Homo sapiens, with a bit of my attributes sprinkled in. So my question is this. This is the frame by which I solve all problems, because these are the characteristics of me and largely the characteristics of you. Are they going to serve us well with this big problem that we've got to solve? This climate change, overpopulation, excessive consumption that we've been talking about for 2.5 days. Are they going to serve me well? I'm going to come back to you on that question, because I think there's some quirks in those characteristics that I've described that aren't going to serve us well, and so do you. Okay, so now to the real talk. That was just me moralising on a soapbox and bullying you into thinking, do we have a bigger problem than we think? And I'm framing that, therefore, not as an earth sciences problem or an environmental problem. Is the problem with us as individuals? Okay, so let me talk about the health system. Let me talk a bit about population and some other things that I'm interested in and you're interested in. So, Population, other people have said much better than I have that we're becoming overpopulated, over-consuming. My slide on that says we reached 7 billion in 2011, and we're now populating at 166,667 times faster than the first billion. That's a fair rate. That's a fair clip. Why? Many reasons. People like sex. People traditionally have had big families because that served them well in a difficult set of circumstances. But also because of medicine, the things I research, agriculture, fossil fuel, energy that we derive from fossil fuels, and it's led to, for that and other reasons, overpopulation. So in a nutshell, this is the world population. Average life expectancy across the world, 67 years. But you guys got lucky. The average life expectancy in this room isn't 67 years. It's much higher. And it came from maybe 200,000 BC and 20,000 BC, where the average life expectancy wasn't so good. If the average life expectancy from 200,000 years ago happened now, you wouldn't have given me an audience, David, to be able to talk to. What about total world population? Well, as I said, it's speeding up, and it's reached 7 billion in 2011. Anybody know when it reaches 8 billion? We're more than halfway there, I think. And the total people who've ever lived, well, a lot of them are living now. And the total people who've ever lived is maybe, I don't know, some anthropologists will have a better estimate than I have. But it's the rate and size of the rate of population growth and the size of the population that's not the crucial bit. The crucial bit is how do we distribute those resources? And there's a growing gap, despite what some people will say, because the rich world keeps on getting richer, has more artifacts, more technology, more things, and the poor world really has largely flatlined to a large extent, most of it. So there's billionaires in the US and China and places like that, multi-billionaires. Half the population lives on $2.50 a day in grinding poverty. Now we're here talking about a planet that they live on. Do we have the wherewithal to be able to comment on that? I don't know what that existence is like, because I'm a rich white dude. I have no idea what that exists. I've done work for WHO and gone to countries where people are living on $2.50 a day in grinding poverty, but I don't know what that's like day after day. I have no idea. Are we speaking for those people? Are the people in Paris speaking for those people? So what's the developed world like, and what's the health system like that's going to look after you? Let's have a think about that. So we're life's lottery winners, but because of overconsumption and embarrassment of riches, for example, the average American consumes 400 more calories per day now than they did a couple of decades ago. So we've got all sorts of diseases of the modern world. Diabetes, heart disease, obesity. Look at the obesity gap. It's less than 5% in Japan, China, and Africa. 60% in the US. I read a stat the other day that 7 out of 10 Australian males were overweight, measured by body mass index. So the costs of those lifestyle diseases trouble me, lifestyle diseases so-called, because it implies that we choose that, except advertising really is powerful, David. So we choose, or we have the lifestyle that we have, and that puts enormous pressure on the health system, especially towards the end of people's lives, later, when we need all that health care. So acute and aged care sectors are very stretched, because we don't really want to allocate more proportion of GDP to healthcare. 10% here, it's getting up to 10%, it's 9.4% in Australia, and 17% in the US. I don't know how they managed to spend 17% of GDP. Essentially, a huge proportion of which is spent on people in the last few months of their lives. If you think about that, that's insane. That's insane. So, let me ask you what you know about the health system that you go to for care now. Who knows what chance there is if you go into an acute setting in a developed country, that's a hospital, in a developed country, what the chance is of you getting an error befalling you when you go in to get fixed up with the condition that you've got when you go in. Some sort of harm induced by the health system. It's called iatrogenic harm. Who knows what chance you've got of some harm befalling you when you go in as an acute inpatient? 80%. Sorry? 80%. The pessimists can stay over here, and I'll talk to the rest of the audience shortly. Yes? It's 1 in 10, so let's get 10% of the audience. You'll do up here. Stand up, please. Stand up. Stand up. So when we all go into hospital, this group representing us is going to get some sort of harm befall them. That is, they're going to have an infection because someone didn't wash their hands. You may sit down. Thank you for being my participants. They're getting an infection. They're going to be on morphine or something or a drug regime and fall and hurt themselves while they're under the hospital's care. Or they're going to have something dramatic happen to them, like they die under anaesthetic. It's only one in every 2.5 million. Or malpractice. You're staying with your pessimistic streak, are you? Okay. It's very important to identify the people who are going to be, asking the toughest questions at the end. Thank you. Okay, so there's one headline number. It's 1 in 10. I don't know about you, but most experts think that's pretty high. When we spent 9.3% of GDP on healthcare, that's sort of a bit high. You roll the dice before you go to hospital, do you? What about how much that we spend on healthcare, 160 billion Australian dollars in Australia, and the OECD average is 9.3% of GDP. How much of the average of that is, I don't know, let's use the word waste. It's done on inappropriate care that shouldn't have been provided. Operations for people with cancer in the last couple of months of their lives. Or who's got back pain? If you haven't got back pain, you're going to get back pain. We're evolved to not brachiate or knuckle walk, but to be bipedally walking around, bipedal locomotion, and our back hasn't caught up with it yet. It hasn't caught up with evolution. Everyone's going to get back pain or they've got back pain. So you need simple analgesics and a bit of TLC. That's what your back needs for the most part. Or perhaps you need a bit of physio. So when you go in and they give you an MRI and an X-ray and a CAT scan, that's uncalled for. Because you're on a pipeline to probably have an operation on your back, which is not needed in the vast, vast majority of cases. So there's all sorts of waste. So who knows what the received wisdom is from the experts on the headline number for waste? Estimates? 40%? I'll have to join you up, this lady over here. Yes, 40%? Higher? My goodness. You've had too much of this climate change, earth scientist, doom and gloom sort of stuff, haven't you? It's 30%. A third. So 1 in 10 chance of being harmed. This is in the best health systems on the planet. Goodness knows what's this like in the third world. That's if you get care of this kind. Okay, so a third of people have to stand up. You'll do. Stand up. So the rest of us are okay. Our expenditure has been meaningful, but this is waste. I don't want to say you're the waster group. Thank you very much for participating. Now, we've done some studies, and there's one other really big study across the world in the US that estimates what proportion of the care delivered in rich health systems is in line with level 1 evidence or guidelines. Now, let me explain. That is to say, you go to the doctor and the care you receive, the indicators for the care you receive, has a randomised trial behind it, or it's the care that's specified by that specialist group for that condition. The doctors themselves say, this is what you should get for this condition, whether it's asthma or heart disease or a kind of cancer or whatever. So what proportion of care do you think, in Australia and in other developed countries it appears, is appropriate in that definition, in line with level 1 evidence, consensus or consensus-based guidelines? It has an RCT or an agreement that that's the care you should receive. This is a study done across 22 common conditions in Australia. 2%. I'm going to have to join you up, and then we're going to give you counselling. 2%? It's 57%. So 57%, okay, I'm going to have you stand up. I'm going to have everybody, including the camera person. Notice I was gender unspecific in my language, except he's a cameraman. Stand up, please, this side of the room. So you will get, we'll put you in the good group, you're the 57%, you're going to get care that's indicated in the technical language, care that's specified for the condition that you have. And I'm sad to say, including my pessimistic friend here, that you're going to get care that just falls below that. Now, it could be awful care, or it could be care that just falls below that which is, thank you very much, that which is sometimes I forget. So that's the nature of the health system. Now, you've been talking about a complex adaptive system, meaning the earth. And I talk about a complex adaptive system, meaning the health system. So if you go into a ward in a public hospital, say here in New South Wales, and you talk to the young doctors and nurses about what's driving their practice, what they'll say is, well, this is the way we do it. This is the practice for whatever the condition is. But I've had a look at the health system in New South Wales, and I've figured out how many policies are in place trying to prescribe the care that should be received in this complex adaptive system. How many policies do you reckon exist applying to a ward or unit? 600 plus. So what people have done is said, these 3 headline numbers are disturbing, so what we're going to do is regulate and issue policy to solve the problem. And that's absolutely nuts, because that's not the way to solve the problem in a complex adaptive system. Now, what are they going to do in Paris? They're going to issue long statements of intent. They're going to try and have policies and regulations to try and fix climate change. Well, it's a complex adaptive system, and it's not going to respond in a one-to-one correspondence with what people put in glossy brochures. No system does. The real way is to work with people on the ground in healthcare and on the planet to try and figure out solutions, because all solutions to some extent are local adaptations. And we often don't figure that out. We often don't figure out the local is important. Just like you've figured out that the gut is important because it's a localized system that's part of the whole. Okay, but that was the rich world. Those numbers applied to health systems that you're going to go to sometime soon. Have I got you scared, by the way? What about the developing world? Well, in 1 minute, 20 children in the third world will have died from poverty and starvation. 20 kids. By the time you have lunch with friends or your family tomorrow, with my words echoing in your ear, 28,000 children in the developing world will have died from poverty and starvation. And that's completely solvable. That is a solvable problem right now if we had the will to solve it. But we don't. Why on earth don't we solve that problem? Now that's a known problem that's absolutely solvable. Yes, it's a wicked problem, and we can have a discussion about the nature of the problem, but that's irrelevant. We could fix that. We don't. Climate change is not a solvable problem of known quantity like that. What chance have we got of solving that when we can't solve a problem like this that's absolutely known, and it's shameful that we don't fix it? Did I say change begins with me? So we produce enough food in the world for everyone, but we don't share it around. And we haven't solved that problem. So climate change isn't completely solvable, is it? We've heard that over and over again in the last 2.5 days. It's certainly not solvable through geoengineering. I had high hopes until I met David, and he gave me his talk this morning. So what chance have we got of putting all our collective mind and willingness together to tackle climate change? So Paris is very important. And you've probably noticed I'm a not natural optimist, but I'm worried. I'm worried. Okay, so being poor isn't good for your health. There's 900 million people who don't have access to clean drinking water. Poor sanitation, high cost of medical treatment. They don't even get the care that I've scared you about in the rich world. Most of which is very good, by the way, despite those headline numbers. There's HIV/AIDS, malaria, leprosy, tuberculosis. A lack of interest from Big Pharma, the big pharmaceutical companies, to do stuff for third world populations. And there's international trading rules where the bargaining power, shall we say, is unequal. So that translates into some interesting data. Life expectancy at birth. I'm doing a study of 60 countries at the moment, looking at 60 countries and their health systems. I've enrolled them all in the study. I wrote a book this year on 30 countries and their health reform initiatives. Those are all the countries. You don't have to read it, but what you can see is life expectancy differs by country. So now before I go on, here's a little thing. Here's a little thing I want to share with you. We've talked about all this poor world. Do you know what that is? Do you know whose? Yes. In one I prepared earlier. I've had my genes sequenced. It's on an iPad. I was enrolled in a study. That's outrageous. The poor world are on $2.50 a day in grinding poverty, and I can have my genes sequenced? That's outrageous. Did I say the world was unequal and the rich were getting richer and the poor were getting poorer? But am I going to stop doing that? Am I going to not have my genes sequenced if the opportunity arises? That's a hell of a dilemma for us in the Anthropocene. That's a hell of a dilemma, is it not? How are we going to do that? I don't even have a mechanism to know how to deal with that. But that's what we've got to figure out. This is a much bigger problem than the babble that's coming out of Paris. This is a really important, crucial issue for humanity, and we don't know how to deal with it. That's the poignancy of the last 2.5 days that I've experienced. So, under 5 mortality rate. Here's Afghanistan, Ivory Coast, Guinea, Nigeria, Sierra Leone. Probability of dying by age 5 per 1,000 live births, around about 100. Completely unacceptable in the rest of the world. These are the data, fresh off the WHO, reanalysed by my group on a study doing 60 countries. Inequity is far worse than we think and far more ingrained in the fabric of humanity. It's far worse than we think. Maybe you know it's bad. Fantastic talk, by the way. But I think as a 7 billion people, we just gloss over this. We run past it. We forget about it. Here's a hockey stick the other way round, I suppose. Sorry for breaking the sort of tradition. Here's a hockey stick that way. That's life expectancy at birth compared to GDP per capita. That's life expectancy. This is GDP per capita. So as you can see, the wealthier you get with that overconsumption that we're worried about also buys you better health, but only to a certain extent, and then it plateaus. You don't get any more. So even if you're Qatar, with sort of an embarrassment of riches, where I was a couple of months ago at a conference giving a talk, now there's a hell of a place to visit. You don't buy any more. You don't buy any more life. So I wonder why we keep bolstering the GDP of rich countries for no more gains and actually just more overconsumption and not spreading it around. I'm sure our economist friend will have something to say about this. So there's also a shortage of health professionals in the developing world, and we're responsible because we keep raiding them for health professionals. So it's not only inequitable, but we get people who are trained to be doctors and then move them out to Australia or the US or Canada or somewhere like that, or Europe. So in Africa, there's 2.3 health workers for every 1,000 people, compared to 24.8 in the Americas, and 1/3 of the world's health workers are caring for 25% of the world's disease burden. We've got to fix these problems. We've got to fix these problems because these are solvable. These are solvable problems. What would I do? I'd give education and resources to women across the world, and I'd put them in positions of power. It's the best bloody solution I know. I even say that after admitting I'm a white rich dude. That's all right, thank you. This is like group therapy. It's fantastic, except for the pessimists over here. So education, sure, we've got population controls and all sorts of other things that people have tried to do, but the reality is if you give education and resources to women, they will distribute that to their family. The kids will benefit. In many societies, if you give money to to men, they'll spend it on grog or something like that. They'll spend it on alcohol or do something not as productive as improving family life and the family's net gains. So, really I'm getting to the end of what I wanted to say because I'd rather have a chat with you. Let me just briefly talk about Australia and then finish. So climate change and population with Australia is a bit funny really, isn't it? Because we've got all this land in the middle. Seems like we've got enormous amounts of land. We could have big Australia with, 100 million people or something like that. That's not a smart idea. That's not a smart idea. So we've got a huge carbon footprint, much bigger than we should for the population we have. I mean, massively bigger than we should, despite what any politicians will tell you. And the climate impact changes on health are absolutely huge, and David and I are actually on a group thinking about and looking at that. And the impact is absolutely huge. Australia is not going to be well served in the Anthropocene as it progresses with climate change. So if we didn't have an incentive to do something, I don't know what would create an incentive for us to do something. So if we're served by politicians that don't acknowledge that and aren't interested in it, we need to vote them out and get a new government. Except I'm worried that I can't see the government that I need to vote for. So we're kind of all trapped, aren't we? We're also in terms of health systems, which I'm really interested in, not just climate and population. We need 1 million aged and healthcare workers by 2025, and this is similar in developed countries, but it's not very popular to be a nurse or an allied health professional or a doctor anymore because you can earn more money or have an easier life and you don't have to deal with death and dying and blood and guts. And so there's more attractive ways to earn a living. But I want to say it's a very rewarding thing to do. And if you're thinking of a change of career, come on over to the health system. We've got plenty of work for you. So what should happen now, my summary is, I need to help through my research to improve the health system that we've got now, because it could do with some improvement. We need more evidence-based practice. We need a more efficient, effective healthcare system, and we need for the stakeholders to come together to work on that with us. It's okay for us doing research, but as you pointed out, research sometimes just goes out into the ether and who knows what happens to it. We need to educate women, and more than that, we need to put women in positions of authority and give them most of the Earth's resources because it would be deployed better than it is now. And we need climate mitigation, but that's the province of other people, so I'll leave them to make that case. And then finally, we need smaller populations, healthier lifestyles, and that's about you and me, fairer distribution of wealth, and affordable quality healthcare for all. Thank you very much.